Welcome everybody, I'm Brian McCourt, President of the McCourt Foundation. And on behalf of the entire foundation, we'd like to welcome you to the 2022 Educational Update. Today, we will have some of the finest minds from Mass General, Brigham and Women's, and Cedars-Sinai presenting on some of the latest topics in MS, Alzheimer's, and ALS. I'd like to take an opportunity to thank all of our sponsors for being a part of this day, but especially our major sponsors, that being UBS Financial, EMD Serono, and MT Pharma. But again, all of the corporations that are being a part of this and making this day so successful. As you all know, our mission is to help cure neurologic diseases. And this is why events like this are so important to us. Today, we'll be broadcasting a virtual portion of this day, so it gives us the ability to have an in-person and virtual option. So we'll have people from all over the country being a part of this. It's exciting because, again, it's important to get the latest information out there. So thank you so much to all of you for being a part of it. Get ready for some exciting information. Take advantage of all the Q&A. And thanks again for being a part of the McCourt Foundation.
Thank you for attending this afternoon, the McCourt Educational Forum. We at UBS are excited and eager to continue to support this educational forum for the great work that they've been doing. Excuse me. Yeah, as you know, you'll be hearing from some of the top doctors from Massachusetts General Hospital, Cedars-Sinai, and Brigham and Women's Hospital this afternoon on the progress and developments in the research of multiple sclerosis, ALS, and Alzheimer's. We believe in the financial service industry that we not only help families plan for their financial future, but we believe that we can help advance critical research and awareness of these various neurological diseases that we're learning about today and this afternoon. I personally am affected by neurological disease in my family and friends. I have friends with multiple sclerosis and Alzheimer's, so I'm excited and eager and glad that I can participate in this session with you this afternoon. We hope that these sessions are helpful. They empower you and your families to continue to pursue and make life better by learning more about these neurological diseases. It's with great pleasure I'd like to introduce Dr. Eric Klawiter, Associate Neurologist at Massachusetts General Hospital and Professor of Neurology at Harvard Medical School. Dr. Klawiter, thank you.
So I also want to extend my welcome to everyone that is here in person, as well as those that are attending the session virtually online today, and those of you that are watching this days into the future. For me personally, this is always a highlight to be able to speak about the work that we're doing really collectively in the multiple sclerosis space. And I think, as I think about the reasons that I, even as a medical student, was thinking about going into neurology and multiple sclerosis, it was really envisioning how the field would change during my career. And I think it's just exciting to see how we have developed treatments, how we have learned and pivoted in the setting of this pandemic, and despite those hurdles, continue to make strides related to research in better understanding and treating multiple sclerosis. So on behalf of all the speakers, we're looking forward to sharing two talks to start the session. And then I think we'll have, what I'm hoping will be a really engaging and energetic question and answer session following the two talks. So for those of you that are here in person, if you have questions, keep those in mind, write them down. We'll have opportunity to address those later. I would like to introduce the first speaker. It's really a pleasure to introduce Nancy Sicotte. I've known Nancy for quite a number of years, and it's really a joy to have this coast-to-coast connection with the McCourt Foundation. And Nancy is one of the leaders in multiple sclerosis. She is a professor of neurology at Cedars-Sinai Medical Center and chair of the neurology department there. She also directs the multiple sclerosis and neuroimmunology program at Cedars-Sinai Medical Center. And I think it's really great to have her speak, particularly related to her role on the COVID task force for the National MS Society. So she has this inside view on just how our treatment of multiple sclerosis has evolved in the setting of COVID over the last 2 years. So it's my pleasure to introduce Nancy.
Can you hear me? Can you hear me? I'm hopeful that my slides are showing and that you can hear me.
Yes, we can.
Wonderful. So thank you for that lovely introduction. And I really want to thank the McCourt Foundation and all of the sponsors for putting on this event, which is really, I think, so impactful to bring us together and also to be able to share the latest updates with interested families, patients, and supporters of the McCourt Foundation. This is how we move things forward. I'm very sorry that I'm not with you in person. I had some work and family commitments that prevented me from traveling. And I always love to come back to the East Coast because I was born and raised in Salem, Massachusetts. And many of you may not realize, but I had one of the thickest North Shore accents. So I always look forward to being in Boston and connecting with my roots. So I'm hopeful next year I'll be there in person. I have been on the West Coast for the last 30 years, and I have been monitoring the weather. And I'm sorry to say that it looks like some snow and rain there. And of course, it's 72 and sunny here in LA, like it always is. So that aside, I'm very honored to be able to present some updates on behalf of the task force that I've been leading, really along with my colleagues and great support from the National MS Society. So just as the pandemic was beginning, I was starting my term as the chair of the National Medical Advisory Committee to the National MS Society. And of course, the timing was such that this was a big issue for people living with MS and other autoimmune disorders. And really, we came together, it's been a year and almost a year and a half, to start talking about the vaccines. That's really what brought the NMAC Vaccine Advisory Committee together. And we imagined that we would meet for a month or two, maybe 3 months, put out some advice, and that would be it. But of course, as everyone knows, the pandemic has been incredibly challenging, dynamic, lots of twists and turns. And we now meet every 2 weeks or so and have staff struggling to keep up with all the changes. But I really do think that I want to acknowledge the work that's been done by the National MS Society. It really has been a go-to place for our patients to find information, not only about the vaccine, but about how to manage with COVID, about the effective disease-modifying therapies, and how to get back into life now. So I'm going to just share my overview for you. I'm going to, I was told to have a relatively brief presentation and then lots of time for a panel and questions. So I'm going to start just sort of at the beginning where we started with the pandemic and thinking about COVID and how it might affect people living with MS. Also then a lot of interest and work that's been done in understanding the role of disease-modifying agents in mitigating or exacerbating risk related to COVID and severe disease. And then, of course, safety and efficacy of vaccination in autoimmune disorders, because this was really what brought the committee together initially, because there is some lingering or had been lingering concerns among the MS community about the role of vaccination. And we were very much hoping to get ahead of that as the vaccines for COVID were rolling out. And then it became very clear that our disease-modifying therapies were going to interact with these with vaccine responses. And so the second half of what we've worked a lot on is trying to provide a detailed guidance for individuals in terms of the medications they're on and their relative risks, and whether timing of administration of medications, for example, could be a benefit. And then some, this was all sort of in a data-free world to start, and sort of the lessons learned are there are a few surprises as the data started to roll in, which I'll go over. And then, of course, we're in a much different place than we were at the beginning of the pandemic, with now several therapeutics that are available to us. So this is giving us some hope as we go forward, recognizing that COVID will be with us. It looks now as we're moving to this endemic phase rather than the pandemic. But I guess many of us, myself included, had this naive thought that it would disappear and we would not have to deal with it. Well, we're going to have to live with COVID. And I think these therapeutics, including some preventative medications, which I'll talk about, could help us make this transition back into a more normal life. And then finally, very briefly, a few updates on long COVID. And I think this could be a very interesting for our question and answer in regards to what are the risk factors for people developing long COVID. So I'll try and do that and not take too much time. So let's cast our mind back now 2 years, which is shocking. 2 years when the pandemic began. Really what we were most worried about to start with, this is way before the vaccines were around, is were our patients going to be at risk for developing severe COVID? And which patients were going to be at risk? And I have to say that one of the really dramatic things that happened during the pandemic, one of the silver linings, is our ability to very quickly have folks ramp up with information to help us with answering some of these questions. And as you remember, one of the hardest hit areas to begin with was Italy. And so the Italian MS groups put together a repository a registry to take information from their patients, so we could start to ask and answer some of these questions. And in the United States, at WashU, under Ann Cross's leadership, the COVI-MS registries that was supported by the consortium, as well as the MS Society, stood up a registry. And then in Sweden, also, information became available. So this was really helpful in helping us to understand what the risk factors might be. Here are some of the papers that were published from the Italian group, from the US group, from Sweden, and then there's also a paper that kind of took all those that information together to start looking at and the disease-modifying therapy relationships to severe COVID. So what did we learn from all of this information that was provided? First and foremost, I would say it's been pretty consistent. And that's actually reassuring that these different registries were coming up with similar findings that help us to then disseminate across the world. Excuse me. So you can see here some of the risk factors that were associated with increased risk for severe COVID. Of course, having progressive disease, being older, male sex is a risk factor. People of color, and especially the Black race, were more likely to have severe COVID. if you were using a mobility device or were in a wheelchair, which correlated with progressive MS, obviously. And then having other health conditions, body mass index, so obesity, diabetes, or heart disease. And then I think the two areas of concern for us as MS clinicians and for our patients is that corticosteroid use in the past 2 months seemed to be associated with an increased risk, and then certain disease-modifying therapies. So what I'm showing you here is the paper from the COVID-MS registry, and this is a detailed, kind of a busy table, but I just want to give you a sense that what they were doing, and maybe you can see my my pointer here, is they looked at the clinical course of COVID, including hospitalization, whether or not you ended up in the ICU or on a ventilator, and then the risk of death. And when they looked at disease-modifying therapy, if we look at these p-values, you can see that a couple of things stood out. And these were the drugs that the so-called B-cell depleters that are very frequently used to treat MS these days, including ocrelizumab and rituximab. And that's in contradistinction to some of the other therapies like teriflunomide, natalizumab, the fumarates, and glatiramer acetate, for example, and interferons, where there was not a relationship between the use of those medications and severe COVID. So we saw that with these B-cell depleters, the risk for hospitalization was increased. When we looked at rituximab, we saw that the risk for hospitalization was also increased. But we do not see a risk for these other more severe outcomes in this particular data set. Also, what was seen is that having exposure in the last 2 months to steroid use increased the risk of being admitted to the hospital. So this started to give us some information about some of the factors that we would need to keep an eye on and advise our patients in terms of their risks going forward. So this then we moved into the vaccine era, and this is, as I said, the time when the group came together, the task force, to provide some detailed updates for patients living with MS in regards to the vaccine. And as you remember, one of the astounding things was the speed at which these vaccines made it into clinical use. And at the beginning, I remember the pundits saying it takes, 5 years to develop a vaccine. And we all know that within 6 months, we were able to get some clinical trials stood up and then within 9 months have a vaccine available. So as one of the reasons why is this delivery system had already been well developed, and the mRNA technology that was used was also well along the way. These two were put together, so we had an easy way to deliver the vaccine, and the mRNA is taken up by the ribosomes. It is secreted by the cell or displayed on the surface of the cell and very efficiently stimulates the immune system, but in a way that does not involve using viral particles or the entire virus. This is just the spike protein, which is the key piece of the virus that attaches to the cells in your nose and in your body that causes the infection. So this mRNA technology allowed us to very quickly move forward with studies. And we all remember, I know I was so happy to see the results here that were in the New England Journal of Medicine for the Pfizer vaccine, demonstrating this benefit of the vaccine in terms of developing symptoms or developing COVID, symptomatic disease. So you see here in the placebo group that there is the risk over time accumulates and the numbers of patients who developed COVID symptoms increased. But you see here that after about 2 weeks after this vaccination, that the number of cases stabilized. So this was very, very exciting, of course, giving us a window to potentially managing some of the scarier, severe symptoms of the disease. So this then sparked, I think, for our MS patients, then some of this kind of lingering concerns about vaccination in individuals living with MS. And this comes, because when you're given a vaccine, you are stimulating the immune system. And the concern that stimulating immune responses then might trigger relapses in MS. So the truth is, and lots of studies that have been done demonstrate that this is not the case. So for example, in the flu vaccines, there have been studies done showing that vaccination actually protects against relapses, because if you do develop the flu, you're at increased risk for having a relapse. I think some of the confusion is that there's some kinds of vaccines that are not recommended for people living with MS, and that has to do with live vaccines. And that's in part because, especially if you're on immune suppressing medications, that a live vaccine you could have a different kind of response that your immune system couldn't control if you were on disease modifying therapies or immunosuppressed. And then another question that came up is, do the new mRNA vaccines pose more risk for people living with MS? And thankfully, we have seen that this is not the case. And then another question, are there interactions between MS treatments and vaccines? Yes, and we're going to look at that in a little more detail because there are some therapies that decrease the effectiveness of vaccines, and that's because of the way they impact the immune system. And then finally, should people living with MS receive vaccination against COVID-19? And the answer, we have now lots of data to confirm this. The answer is yes, you should get vaccinated. So just to answer these questions again, just to emphasize again that this really, really a critical piece of managing MS during the COVID era is to get vaccinated. So we see no relationship between vaccination and relapses. As I said, viral infections can potentially cause a relapse. So if you can be protected against that, that's even more benefit. Now, truthfully, we know that no vaccine is 100% safe. There have been cases of people having adverse reactions or even anaphylaxis to the COVID vaccine and to any vaccine. So what's really important is weighing the risks and the benefits of the vaccines. And this, I think, is very difficult, because if you happen to have a side effect of a vaccine, your experience is 100% of the time this was a reaction to the vaccine. But if you look at population data, you can see the risks are very slow and very low. They're in the less than 0.1% range, whereas the risks of developing COVID are very high, and that includes death as well as lingering symptoms, hospitalization, a long recovery, and so forth. So this kind of risk benefit we found to be even more important with COVID. And again, as I said, if you really think about it, we've done sort of the largest clinical trial, if you will, in the history of the planet, because these vaccines have been deployed across the globe and with millions and millions of people who received the vaccine. So we have a lot of very, very good data. And the data overwhelmingly showed that the vaccines are safe and effective. So you may know that there are different kinds of vaccines in the United States. Really, it's just these three, the mRNA vaccines from Pfizer, and then the Moderna vaccine, which is very similar, and then the Johnson & Johnson. Johnson & Johnson uses a viral vector, but it's non-replicating, so it does not cause a viral infection. These other vaccines are not available in the U.S., so I'm not going to spend too much time talking about that, but these are the three that we have in the U.S. currently. So, are these vaccines safe? Yes. And, in the initial studies, these were not tested specifically for people living with MS, but we have an excellent safety record, as I said. So just so that you know, there are some adverse events, but these are very rare, and we know that they can vary by population. And again, this is from all of this data that's been collected since the vaccines have been on the market. And so the J&J vaccine, for example, in women under the age of 50, that was associated with the risk of clotting. And then the mRNA vaccines, there was some risk of myocarditis in adolescent males. So this will help us in figuring out which vaccines might be more appropriate for the right populations. So what about these vaccine responses that we're hoping to get nice, robust immunity from the vaccines? How does this affect or interact with our disease-modifying therapies? Well, we needed the data. We had some ideas, but one of the first sets of data came out of Israel, And this paper was very influential and interesting for our task force to review. So for one thing, we saw, this is a graph showing these the SARS-CoV-2 antibody titers. So after you get a vaccine, you want these antibody titers to be high, like you see in this control group here. You want to see a change from the baseline to a high level, and these are called neutralizing antibodies. These are what bind to the spike protein and prevent the virus from getting into the body. And you see that in these situations of untreated MS patients, and surprisingly to our group initially, cladribine-treated patients had normal responses. But we can see here that those who are on ocrelizumab had, in general, a much lower antibody response, and as well as fingolimod, which is what we call an S1P inhibitor. So this was the first hint. I'm sorry, I don't know where that came from. This was the first hints that there might be some concerns about some of the disease-modifying therapies and the effectiveness of the vaccine. So further data, this is from Amit Barour and his group that was published in Nature Medicine, demonstrated that even though those antibody responses might be less than you would see in individuals who are not on disease-modifying therapies, at least in the case of these anti-CD20 medications, so these are the ones such as rituximab and ocrelizumab. In that case, we saw, as demonstrated here and in this graph here, that T-cell responses were actually preserved or enhanced after vaccination. And so your immune system makes antibodies as well as these T-cell responses, and these seem to be preserved in anti-CD20 treated B-cell depleted patients, which is very encouraging. So this is a very complicated kind of cartoon showing you that vaccine responses involve the whole immune system. And I'm not going to go through that in detail because of the time, but I think the take-home points are that there are multiple immune responses that give us protection from viruses. The neutralizing antibodies help block the infection, but the T-cell responses help us clear the virus. So this is why, even though we see these breakthrough infections, as they're called, which is really not the right term to use, even though we see that people vaccinated do get infected with COVID, their course is much less severe. And that's most likely due to the fact that their T-cell responses are clearing the virus more quickly than if they weren't vaccinated. So another point favoring the use of vaccination. So just to sort of kind of go summarize what we've learned about the effect of DMTs or disease-modifying therapies on COVID and COVID vaccines, I'm just going to, this is sort of a summary slide showing, just to reiterate that there's some evidence that certain disease-modifying therapies can increase the risk for severe COVID. That includes the B-cell depleters as well as well, those are the ones that have mainly been shown, that perhaps the S1P inhibitors. There is some evidence that immune responses to the vaccine may be impacted by disease-modifying therapies, but importantly, the vaccines are still safe, even if the vaccine response might be suppressed. And that other immune responses besides the antibodies are going to be helpful for giving protection against COVID. I haven't talked about this in great detail, but we have data showing that the timing of when you get your B-cell depleter can increase your response to vaccination. So essentially, the longer you wait to have your vaccine after you've had your B-cell depletion treatment, the better the antibody response will be. Currently, though, we're not recommending that COVID vaccine antibody tests be done to determine the vaccine effectiveness, because we have enough group data to suggest that those antibody titers may not be the full answer as to if you have protection from the vaccine. And if you're interested, there is very detailed updated guidance that's on the National MS Society website, as shown here. So after the vaccines were deployed, and based on some of the data that I showed you, and also data from individuals who've had organ transplants, there was more meetings and concerns about those who are immunocompromised. and whether there needed to be more specific guidance for those individuals with the recognition that the antibody responses to the vaccine were not as strong. And so they devised and looked at recommendations based on immunocompromised individuals. And so I just thought I'm showing here where our patients living with MS are on this list, because this is active treatment either with high-dose corticosteroids or other drugs that suppress the immune response. So that's where MS patients fit into this regime. And so what has been developed is further recommendations, which has been, I think, somewhat confusing for those individuals who are immunocompromised. The primary series now, rather than getting 2 doses, as is the case typically, the recommendation is now that the primary series involves 3 doses. So these are people who are not expected to mount a normal immune response. And then that the next step would be to have a booster dose, but and that's up to within at least 3 months. So even after 3 months, then you're eligible to have a booster dose. For Moderna, very similar, just noting that the booster dose for Moderna is a half dose. So the primary series for Moderna is 3 full doses and then a half dose for a booster. For the J&J, also the primary series is that you have 2 doses and then a booster. The second doses in the booster are now currently recommended to be mRNA vaccines because of efficacy. So now we have more evidence to support the use of additional doses in individuals who are living with MS who may be immunocompromised. So now we come to the therapeutic era for COVID, and this is, I think, very exciting. This was I wanted to put an easy to see graphic because this is complicated, and we, again, don't have a huge amount of time, but on the arkansas.gov website, I was surprised to see this. But now we have treatments for those individuals. So you're vaccinated, you get an infection. Now what do you do? Especially if you think you might be at risk because you have some of those risk factors, or because you maybe didn't have a great vaccine response because of your disease-modifying therapy. Well, we now have therapies that can help speed up recovery and decrease the severity of the infection, and those include these monoclonal antibodies and these oral antivirals, for which we're very excited. And in particular, Paxlovid seems to be very effective. These can be complicated to use, and so you absolutely have to go through your healthcare provider, but it does offer us, again, some reassurance as we're moving from pandemic to endemic that we're going to have ways to treat infection and to be able to go out and live our lives. And then, excitingly, a drug that gives protection before exposure to COVID. And this is really intended for that group of individuals who are not expected to have a good vaccine response. And this includes some of our MS patients. So this Evusheld, shown here, these are monoclonal antibodies also, but it's kind of like getting the antibodies that you didn't make from the vaccine. So it's what we call passive immunity. So you're getting the antibodies, they're injected intramuscularly, and they provide protection that is against infection for up to 6 months. So this is very exciting for those patients, especially who've been sitting at home, afraid to go out, worried about getting infected. This is one more piece of protection that our patients can have. Now, there's a couple caveats. You have to complete the full COVID vaccine schedule. That includes the booster in order to be eligible. It's not a replacement for vaccination, and the supplies of these have been limited. But we've had some success, especially with our B-cell depleted patients, getting them on this, and it really does make a difference psychologically. So the last topic, very briefly, long COVID. So this is a really difficult but fascinating topic because we see that large numbers of individuals who've been infected with COVID, even with mild disease, go on to develop what is long COVID, which is sort of ill-defined but recurrent symptoms, or symptoms that don't improve after the infection is gone, including brain fog, fatigue, muscle aches, shortness of breath, and autonomic excitability. there's a lot of overlap between some of the symptoms we see in our MS patients, to be honest, and really interesting, especially since we're going to hear an update on Epstein-Barr, is that this recent study in Cell identified 4 characteristics that were risk factors for developing this now called PASCI, or post-acute COVID-19 sequelae. And this includes viral load, so if you had a lot of virus, if you had the autoantibodies to start with, which is interesting because a lot of our patients living with MS do have other autoantibodies. If you had a reactivation of Epstein-Barr virus at the time of the infection, and if you had diabetes. So we're starting to get understanding this a little bit more, but this is an area that I think we're going to be looking for data going forward, and especially how we treat these patients. So I went way longer, I think, than I was supposed to, but was a lot to unpack. I just want to acknowledge my colleagues within the NMAC Vaccine Advisory Task Force, who you see listed here, and in particular, Julie Fiol, who has really done yeoman's duty getting this work done and keeping us updated. And then I just want to acknowledge my team here at Cedars-Sinai in our Neuroimmunology program, who keep us going every day. So thank you for your attention, and thank you for this opportunity. I will stop sharing my slides, and I look forward to our conversation for the panel. Thank you.
Great. Thank you so much, Dr. Sicotte. That was a really comprehensive overview of COVID and how that relates to multiple sclerosis. So hold your questions. We will have an opportunity for Q&A after our second talk. And that now is a transition to Dr. Anastasia Vishnevetsky, who is a fellow at the Brigham and Women's Hospital, Mass General Hospital, Multiple Sclerosis and Neuroimmunology program. She has a special research interest in clinical trials, and on the clinical side, works in our neuroimmunology clinic, where she, in addition to seeing patients with MS, has a lot of clinical experience seeing patients with diagnoses perhaps on the periphery of MS, or conditions that sometimes can be misdiagnosed as MS and vice versa. So with that, Anastasia, please tell us a little bit about the differential diagnosis of MS.
Thanks so much, Eric. So first, I just wanted to thank the McCourt Foundation and the sponsors who helped make this day possible, and in particular, everybody who's come in person and everyone who's joining us virtually today. So I'm Anastasia Vishnevetsky, a neuroimmunology fellow. I work particularly closely with Dr. Levy in the Neuromyelitis Optica clinic. And I'm going to be talking about some cousins of MS, specifically neuromyelitis optica and MOG antibody disease today. And what I think is actually really helpful in understanding how neuromyelitis optica and MOG became separated from MS is understanding the history of how we got here. So back in the 19th century, in 1894, Dr. de Vick described a disease affecting the optic nerves and vision and the spinal cord, and causing particularly severe manifestations in both of these. And for a long time, the condition he described has been called de Vick's disease. In 1999, de Vick's disease, also now called neuromyelitis optica because it affects the spine, and inflammation of the spinal cord is called myelitis, as well as the optic nerves. The first definition was put together based on MRI criteria. At this time, though, and really for the last 20 years, 30 years before that, this was considered to be kind of on the MS spectrum. The same way we know that there are many different types of MS. Some people have a more benign form, others have a more aggressive fulminant form. Some people might have primary progressive, and others might have a relapsing remitting disease. This was thought to be one more MS variant. That really all changed in 2004, when a specific autoantibody was found in patients who had this neuromyelitis optica type of presentation. Just the next year, in 2005, the target for that antibody was found. So with that, with a new antibody and the target that actually caused disease, neuromyelitis optica became its own separate disease from MS. About 70% of patients who looked like they had DeVick's disease or neuromyelitis optica actually had these aquaporin 4 antibody channels. 30% of those who looked like they had neuromyelitis optica didn't have that antibody. So we kept looking for more antibodies that would be a sign of this disease. And in 2011, another autoantibody was identified. That antibody is myelin oligodendrocyte glycoprotein, or MOG. And a portion, about 30 to 40% of those who didn't have aquaporin 4 but looked like they had neuromyelitis optica, about 30–40% of those had MOG antibodies. And if there's one thing that I think is helpful to take away from this talk in terms of thinking about, I want to learn more about neuromyelitis optica or MOG antibody disease and looking for additional resources, takeaway is that right now, the nomenclature and how we call these diseases is really muddled. And so it's helpful to understand what people are talking about when you look at online resources, and realizing that actually there's many different correct ways that experts are going to refer to these, and that's constantly changing. So for a while, MOG has been considered part of neuromyelitis optica or neuromyelitis optica spectrum disorders, NMOSD. And many people will still consider MOG kind of under that umbrella. More and more, though, we're realizing that MOG is its own disease with its own pathophysiology, a very different prognosis, and different treatments. It also can cause things that don't look like neuromyelitis optica. But when you just first present to a doctor, MOG and aquaporin 4-related NMO can look virtually the same. In the last few years, the landscape has really changed significantly, in particular for aquaporin 4 disease. So in 2019, 3 new FDA-approved drugs came on the market for aquaporin 4 related disease. So I'm going to talk a little bit more about the differentiating MOG, aquaporin 4-related NMO and MS, and also some of the new developments, in particular in the aquaporin 4 NMO space. So separating out MS versus MOG antibody disease and NMO, and as you'll see, I kind of still put MOG and aquaporin 4 NMO under this kind of umbrella of NMOSD. In terms of the biomarkers for MS versus NMO, many of you may know that for the diagnosis of all 3 of these, we typically have a spinal tap and get cerebrospinal fluid. And about 90% of patients with MS might have oligoclonal bands. That's one of the best biomarkers that we have in MS. We don't have a single yes/no diagnosis or biomarker for MS. For MOG, there's a blood test that shows us if we have this autoantibody, and that really is what makes the diagnosis. The one caveat there is that some patients with MS may have very low levels of MOG antibody, and we know that that can happen. With NMO, and particularly aquaporin 4 positive, there's a very good test in the blood, and you can also send it in the spinal fluid, and that's for aquaporin 4. And there have actually been no cases of patients who've had MS and also had aquaporin 4 NMO. So those are pretty much mutually exclusive. In terms of the pathophysiology for MS, it's really quite complicated, and there's still a lot that we're sorting out. There's a lot of new excitement surrounding EBV in the pathophysiology of MS, and we might talk about that a little bit later. And there's a complex T and B cell interaction. We know that both of those are involved because we have drugs that target both of those and are effective in MS. In MOG, there's a clear target on oligodendrocytes, which create myelin, and so it's a myelin-targeting autoantibody-driven disease. And even though we think of this whole group of diseases as demyelinating diseases, Aquaporin 4 is actually a water channel on astrocytes, which are another cell that supports neurons. So it's an entirely different mechanism from MS and also from MOG, even though on the surface, initially we thought that these were pretty much the same disease. Another really key differentiator that I think is really important for patients is that progression in between relapses is really more of a characteristic of MS and not of MOG or of NMO. In MOG and in NMO, the relapses or disease attacks can be really quite severe. And in particular with aquaporin 4 disease, often there's not very good recovery. So preventing relapses is really the name of the game. In MS, you can often have a relapse with relatively good recovery over time, but then continue to have progression between relapses. In terms of other clinical manifestations, the reason these three diseases were thought to be so closely related is because all three of them target the optic nerves and the spinal cord. But the way that they do that is different. So in MS, it's often just one eye at a time, almost always, and it can be a short portion of the optic nerves that's affected. The visual loss is often not that severe, and the recovery can be very good. In MOG and in aquaporin 4 NMO, the vision loss can be more severe. Both eyes can be affected at the same time. That's often one of our kind of biggest giveaways that this is going to be NMO rather than MS. And often a longer portion of the optic nerves is involved. There's also other subtle differences, like MOG affects more the periphery of the optic nerve, and NMO, aquaporin 4 NMO, is more likely to affect the back of the optic nerve. In terms of the spinal cord, both MOG and aquaporin 4 NMO have very long lesions in the spinal cord typically. In about 80% or so of cases, over 3 spinal cord levels are involved in a given lesion. In MS, it's more patchy. Shorter portions of the spinal cord are involved, even though the manifestations, the symptoms patients might experience can be very similar. And then there's also kind of additional kind of add-on symptoms that distinguish the different diseases. So it's more common in MS to have symptoms like fatigue, cognitive fog, and a lot of other signs that suggest that this is a diffuse brain process, as we know it is. In MOG, sometimes the very bottom of the spinal cord is affected, a portion that's not really affected in MS, that's called the conus medullaris. Can affect bladder, bowels, things like that. And you can also get these big fluffy lesions that can almost look like an encephalitis at the beginning of the disease. In aquaporin 4, you can get a really classic syndrome of nausea, vomiting, and hiccups, which we don't typically see in MS or in MOG. And that can be a giveaway that this is going to be aquaporin 4. In terms of the treatments, the acute treatments initially up front are relatively similar between the three conditions. We often start with IV steroids to treat an acute flare. But for MOG, we also often use IVIG. That's been tried in MS and sometimes will still be used in patients who don't have a good response to steroids, but we don't typically use it for MS, and we don't typically use it for aquaporin 4 related NMO. In NMO, we know that plasmapheresis most likely gives a benefit on top of steroids, so that's often used pretty early on with aquaporin 4 related relapses. All three of these use immunotherapy to control between relapses. But with MOG, sometimes people will, about 50% will just have one attack and then never have another attack again. So typically we don't treat after a first attack. Whereas with MS or with aquaporin 4 NMO, we'll pretty quickly start immunotherapies. The therapies that are helpful for MS also have not been shown to be helpful for NMO or MOG, with the exception of B-cell targeting therapies like rituximab or ocrelizumab. So sometimes a picture is worth 1,000 words, so I just wanted to show a little bit of a snapshot of what I mean that the diseases look different, although this could be its own topic all on its own. But in the first panel, you see a kind of typical MS lesion with just a short little lesion. The lesion is the white area and what's supposed to be the gray spinal cord going from top to bottom. Compare that to the image next to it, which is a typical aquaporin 4 NMO case, where you see this long white expanse going more than 3 spinal cord levels. We look at the bones to say how many levels there are. Another thing that's a little more subtle that you might see, and this is just from patients that I saw in the last couple of weeks, is that this patient looks like maybe there's a little bit more arthritis in her neck. And this is actually a patient who's 90 years old and presenting with her first ever attack of aquaporin 4. So that just speaks to the fact that the epidemiology of these is quite different. So MS typically affects younger individuals, 20s, 30s, sometimes even younger patients and sometimes a little bit older, but you're not going to see anyone with a new presentation in their 70s, 80s, or 90s. Aquaporin 4 NMO has been described in terms of new onsets and new attacks really across the age span, from 3 into people's 80s and 90s. The average age of onset for aquaporin 4 disease is in the 40s, and the female predominance is even more pronounced than for MS. So it's 7-to-1 female to male ratio. MOG, on the other hand, MOG antibody disease, is more likely to affect the young, and the female to male ratio is really not a prominent feature. And here I'm showing a picture of optic neuritis in MOG-associated disease. And if you can see at the very back of this picture is the optic nerves, and this optic nerve is kind of highlighted by white in a way that the other side is not. And that is contrast, and that's inflammation in the periphery of the optic nerves, not in the middle. In MS, you would see it more likely in the middle, and it would be much less of the nerve that's affected. So if someone saw this kind of MRI, they would think about MOG antibody disease causing optic neuritis. So that really kind of brings me to the next question of who should be tested for NMO or MOG. If you have been diagnosed with MS, should you be worried about that? And are people going to know to test you for these newer or more newly described conditions? The first thing I'll say is that testing frequency in general is really increasing. We've learned so much about both of these conditions over the last few years. And really all neuroimmunologists now widely recognize and are comfortable with the diagnosis of these conditions. Many more patients who are going to be diagnosed with MS today are going to be tested for these, although in most cases, over time, the diagnosis does become clear. So who are the patients I typically think about testing for? Anyone with optic neuritis that has atypical features for MS. So if it's involving a longer part of the optic nerve, if it's involving the periphery, if it's involving the very, very back or the chiasm, if both eyes are affected, or if the vision loss is particularly severe or not responding to therapy. Those are all patients I would think about. In addition, if someone has an MRI that goes together with either a spinal cord or an optic nerve attack, and it looks abnormal but doesn't look typical for MS, or even if it looks totally normal, those are patients when, if there's a spinal cord or vision attack, I would think about sending MOG and NMO antibodies. If anyone has any of those typical clinical features, the hiccups, nausea, vomiting, or the bottom of the spinal cord lesions, or these really long spinal cord lesions, all of those patients today are going to get tested for MOG and NMO. And one final thing is if someone has a really poor response to MS therapies, in the sense that they're continuing to relapse through relatively aggressive therapies like Tysabri or natalizumab, that might be something that makes me think about, is it worth revisiting the diagnosis? That being said, a lot of times when we see people who are struggling even despite therapies, it's because there's progression between relapses. And those patients typically are not the ones who are going to end up with a different diagnosis like NMO or MOG. I want to transition now into talking a little bit about the success story of aquaporin for NMO and how we've kind of gotten to the place where we have 3 new FDA-approved drugs, as well as recent kind of renewed evidence for rituximab, which we've been using for a long time. And this is kind of really sprung out of great and very rapidly advancing science in aquaporin 4 NMO. And so looking at the bottom panel over here, this is just really showing the progression of how white blood cells, or a portion of our white blood cells called B cells or B lymphocytes, produce antibodies. And B cells have have different markers on the surface of the cell. One of those is CD20. That one might be very familiar to all of you because that's what rituximab or ocrelizumab target. And that suppresses B cells. And as you just heard, that has implications for COVID and for vaccine response. And that's really an immunosuppressive mechanism. In Neuromyelitis optica, where we really know that antibody production is what drives the disease, a thought was, well, is there another marker of B cells that's even broader than CD20? And so CD19 is another marker that affects even a wider range of B cells, including plasma cells, which are the kind of final cell that produces antibodies. And so this drug, inebilizumab, is used to target CD19, but ultimately has a very, very similar kind of mechanism of action to rituximab. And so inebilizumab has been shown to be effective for neuromyelitis optica. There's also an IL-6 receptor on B cells, and this has a bunch of different effects, including stimulating antibody production, helping B cells survive, and generally kind of acting up and revving up the immune system. And so another drug called satralizumab has been developed to block that receptor and has also been effective in neuromyelitis optica. So this is a pretty different mechanism, also monoclonal antibody, but very different mechanism. And then finally, when the antibodies get into the brain, they go for their target, which is this aquaporin 4 channel on astrocytes. And the way that damage ends up happening, one of the ways, is that the astrocyte ends up being destroyed. And we know that there is activation of the complement system, complement cascade, that ends with the production of a membrane attack complex that then stimulates destruction of the astrocyte. And so a third mechanism and a third drug that's been developed is eculizumab, which blocks the complement pathway and stops this destruction. So the main treatments for NMOSD today, immunotherapeutics that are new, are eculizumab, satralizumab, inebilizumab, and rituximab. There have been 2 trials for satralizumab, a very small trial for rituximab, and larger trials for both inebilizumab and eculizumab. I think the kind of main takeaways, there's a lot of things that distinguish the different trials and also the different drugs. But I think the main takeaways are that in the era of the COVID pandemic, we think about rituximab and inebilizumab as the more immunosuppressive treatments that have implications in terms of COVID vaccine response. They don't seem to increase the number of additional opportunistic infections as significantly as we initially thought, and that's the case for ocrelizumab as well. Eculizumab seems to have the best efficacy based on the clinical trial data, although it's hard to compare different designs and slightly different definitions and outcome measures. But it had a really dramatic response in the aquaporin 4 population. But it's limited by the fact that it needs an infusion every 2 weeks. And so this is a lifelong therapy, and patients need to be able to get an infusion every 2 weeks. So satralizumab is often used just for kind of practical reasons. It's a once-a-month injection, whereas inebilizumab and rituximab are both an infusion that's used every 6 months. There are a lot of exciting changes that are coming, or a lot of exciting developments in both MOG and in aquaporin 4, neuromyelitis optica, and in that group that has neither of those, which really kind of we group together with the aquaporin 4 disease for now. In MOG antibody disease, there's an upcoming trial of rozanolixizumab, and that is essentially using a drug or an antibody to kind of replicate the effects of IVIG, which we know has been very effective in MOG, although there aren't randomized clinical trials and there aren't any FDA-approved drugs for MOG. We do, sense that there's a very significant degree of efficacy for IVIG, and so that's what rozanolixizumab is based off of. There's also a clinical trial of satralizumab, so the same one that we used in aquaporin 4, now setting out to see if that also works for MOG. And then in aquaporin 4, there's going to be trials of BTK inhibitors, and there's also a clinical trial of ravulizumab, which is a cousin of eculizumab, the complement inhibitor, that is only requires treatment every 8 weeks, so it becomes much more practical, but hopefully will have the same effects. I think this is often underplayed, but I think one of the other things that's going to be really important in the coming years is all of the additional data that's coming out from the open label extensions, as well as from just real life day-to-day use of these drugs. We don't really have any studies yet on comparative effectiveness, which one's more effective, but I think we're going to start to see, retrospective cohorts that'll help us understand how are people doing in real life with these different with these different drugs. And there's also more recently been some study looking at to what degree do these drugs, even if there are relapses, actually decrease relapse severity. And so that's going to be another kind of area for future research. So with that, I want to thank you all for listening, and I'm very happy to answer any questions in our Q&A.
Thank you, Anastasia. That was a wonderful presentation. So that brings us to our question and answer portion of the afternoon. There are 2 options for asking questions. There are note cards at your tables for those of you that are here in Quincy, and feel free to write a question down and pass them to people that will be circulating to pick them up and to bring them up to me, or there will also be a microphone if you wish to ask a question. We also, there were questions that were submitted in advance, so I have some of them. So we won't have awkward pauses waiting for the next question. So I thought I would kick this off by asking Dr. Sicotte. So I think it's unique to have someone that has a bird's eye view to the National MS Society Task Force on COVID. And many times, even as clinicians, we see these recommendations come out from groups. I would be very interested to learn a little bit about the inner workings of the committee and the task force. So how do you identify the areas to weigh in on? And I imagine with a committee, there's a need for consensus, and how strongly do you make any of these recommendations? So I'd be really interested to hear a little more.
Thank you, Eric. It's a great question, and it's really something that we talked very explicitly about when we put the task force together, because as you recall, we were in a data-free zone at that point. And there were people who were publishing recommendations, very detailed recommendations about which medications to use and which ones not to use and so on, based on, best hypothesis. So we were trying to thread that needle between wanting to be guided by the data, but then also wanting to be useful. And so that requires making more of a definitive statement so that we could be helpful to our patients. So I think the other thing to step back and recognize is the way that the National MS Society operates is really from a patient-centric view. And so they are driven by the needs of their constituents, which is people who are living with MS. So a lot of the things that we addressed were being driven by questions that patients living with MS were bringing to them, such as, should I get a vaccine? Is it safe? Am I at risk for COVID? What about my disease-modifying therapy? Should I stop them? Should I change the cadence with which I'm using them? So we were really wanted to be very pragmatic, but we were also cognizant of the fact that we didn't want to speak with too many voices because it's so complicated for patients. So actually, right from the beginning, we worked very closely with our international partners in Canada and the MSIF, the MS International Federation, and we actually worked to harmonize our advice across those different groups. It's also challenging because there are different vaccines, for example, that were approved in other countries. So they had different advice. They had different regulatory agencies that would make different recommendations. So, but whenever possible, we tried to speak with one voice for the MS and neuroimmunology community. I want to emphasize that we also, a lot of the work that we did is applicable to those living with other neuroimmunological conditions such as NMO and MOGAD. So, so it was a really interesting and continues to be a really interesting process. We became a target at some, whenever you put yourself out there. And for example, I will use the cladribine example. That was on our list of medications that we thought initially would lead to lower vaccine responses based on mechanism and so forth. And it turned out when the data was made available that wasn't the case. We modified our advice based on that. So I think we were trying not to be getting ahead of the data, but at the same time trying to give people advice that they could use based on best available data available. And then I would also just emphasize the fact that we coordinated with our other partners was really impactful. And so going forward, I think it's a great model for whatever is awaiting us in the future. So thanks for that question. Really thoughtful question.
And just a follow-up question. This is one that comes from those attending here in Quincy. To preface this, thank you. At MGH, at least, we're still doing a lot of work, and these are multi-center studies looking at vaccine efficacy. And there's an NIH study that we're participating in looking at switching from one vaccine type to another type. And then you had mentioned in your talk there are these monoclonal antibodies as well that are starting to be used, both for the acute treatment of COVID, but also as pre-exposure prophylaxis. And so I think there's a fair amount of interest related to Evusheld, which was initially available, at least in Boston, in very limited quantities, but now we're able to more adequately get patients this treatment. The question from the audience is related to that treatment. And so could you speak a little bit about the time? You talked about the timing of the vaccine. Are there any considerations related to the timing of getting Evusheld related to the treatment for MS that they might be on? And I'll add another question, also just related to when someone has received one of the COVID vaccines as well.
So I think the most salient point has to do with when you've received the vaccine, because these are anti-spike antibodies that are part of Evusheld. So the recommendation is to wait at least 2 weeks after you've had a vaccination before you would be administered Evusheld. So in terms of the disease-modifying therapies, again, this is passive immunity, so we don't think that there should be interaction. Now, when you have multiple monoclonal antibodies introduced into your system at the same time, there's a theoretical possibility of interference. So Again, recommendations I don't think that are based on pharmacokinetics, but just sort of pragmatic would be to wait at least 2 weeks after an infusion therapy before utilizing the Evusheld. But again, this is a passive immune process where the antibodies are administered and then provide protection for 6 months, at least from the initial studies. I've now seen data potentially suggesting it may not last quite that long. But yeah, I think that just in terms of the ongoing work, it's very complicated in answering some of those questions, which is why these studies that you're discussing are really important. We have an ongoing project here to look at antibody responses among a variety of populations, including our MS patients. And I think the missing piece, truthfully, we see lots of this data now looking at the antibody titers and antibody complexity, which I think is another really interesting question. But we are lacking a little bit of the clinical outcomes. And what does it mean? And does it have a clinical impact if your neutralizing antibodies are low? So I think we certainly, as I said, saw in the early stages that the B-cell depleted patients did more poorly. And there is some evidence from the Delta surge that those that were on B-cell depleters, even though they were vaccinated, were at an increased risk. We don't know for sure, though, with the Omicron variant. And I will say from our own personal experience here, we had a lot of patients on B-cell depleters, and we've had over 100 patients who've had COVID. But in this last surge, none of them were hospitalized. So I think when we're trying to unpack these questions about how to advise people, it's complicated by these layers of different variants versus vaccine timing and vaccine responses on DMT. So it becomes, I think, a more personalized discussion with patients in terms of their own risk factors. And also the other factor is the conditions on the ground. So if you're in a situation where there's a lot of COVID transmission, risks and decision making may be different than if you're in a relatively quiet period. So, for example, here in LA now, the positivity rate is less than 1% for now. So now's a good time for our patients to get out and maybe enjoy the sunshine. So, great question.
I would echo that experience. With the Omicron surge that we had, at least in my practice, I probably had as many patients diagnosed with COVID within about 2 months as I did in the previous 2 years. But outcomes have been quite good, sort of with this latest surge. I think Nancy, maybe you can weigh in on this. I mean, we probably don't know the answer. Is that because of being in the age of post-vaccination right now, or is it related to changes in COVID related to this latest variant? Or is it because of some of the treatments that we have available? So for instance, we're now using these monoclonal antibodies within days of diagnosis when symptoms are very, very mild from COVID. What's your sense, or is it a combination of all three?
It's a hard question to answer because of all the factors that you've discussed in it. You're just reminding me, the anecdote I tell is on Monday mornings, I do all my virtual visits. And there was a Monday in January where I had, 8 patients scheduled and 4 of them had COVID while I was doing my virtual visits with them. They showed up. They had a little sniffles, but in general, it was a mild disease. So I do think that Omicron was different, and I say that based on other reports, but also just here in Los Angeles. If you look at the peak of the number of cases, and then you look at the hospitalizations, it was a much smaller fraction. Now, of course, that is post-vaccination, but I think even with the Delta surge and beyond, the numbers of people that were ending up with disease severe enough to be in the hospital seem to be less. And that was before widespread use of, I think, a lot of these more accessible treatments. But you raise a good point. It's going to be hard to disentangle that completely. I am incredibly grateful that we had this backdrop of people who were vaccinated and a likely less virulent form of COVID, because honestly, I don't think our medical system would have been able to cope if we had had the same proportion of people coming into the hospital during the Omicron surge, because it was, I mean, off the charts. And I'm sure it was the same in Massachusetts as well. So I think this data will come out, but as you suggested, it will be nuanced based on all those factors we talked about.
So we got a number of questions that came in related to this renewed interest in the Epstein-Barr virus as it relates to susceptibility to multiple sclerosis, and Dr. Vishnevetsky has a interest on a research side to this very topic. So I thought maybe I would let you comment just a little bit about this. There have been a couple really prominent papers that have been published recently, and sort of how has that shifted perhaps our mindset related to EBV, and what are some potentials, I think, even related to prevention of multiple sclerosis?
Yeah, absolutely. Are you guys able to hear with the mic right now? Yeah? Okay. So the thought that EBV and MS are related has been around for a long time, and it had kind of been waning, I would say, up until the recent couple of studies. So 2 studies came out coincidentally around the same time in January of this past year that addressed, I think, 2 of the most important questions related to EBV and MS. One of them was an epidemiology study that looked at, is EBV infection necessary for essentially the onset of MS, or for the development of MS? And the other study looked at, if EBV is related to MS or is part of how MS is caused, how does that happen? And what is the mechanism by which EBV might be causing MS? So I think the first question of, just does EBV cause MS? So I think the way I would phrase it is that EBV is almost certainly necessary, but not sufficient to develop MS. So 94% of adults in the United States have been infected with EBV in the past. But 94% of adults do not have MS, not even anywhere near that. The difference is that almost everybody who develops MS has been infected with EBV. It's not 94%, it's really much greater than 99%. And so what the most recent study did was look at, okay, is that because people who have a susceptibility to EBV just also happen to have a susceptibility to MS? Or does, we know that MS onset or diagnosis might be delayed past the actual onset of the disease processes by many, many years. Another question is, does early MS essentially cause you to be more susceptible to EBV? So there were a lot of questions about what direction is this kind of relationship going in. And so the most recent study looked at a huge database of patients, or of individuals who had been actually serving in the Army and who had had their blood drawn at different points, and looked at what percentage of those people had who developed MS had EBV. And pretty much all but one person who developed MS was positive for EBV. And they looked at people who essentially at the beginning of the study did not have EBV positivity, and looked at, before they, over the next several years, essentially develop MS, what percentage are going to convert to having been exposed to EBV. And in that same time period, who were didn't initially have EBV and didn't turn out to have MS, about 57 over those several years converted and had had been exposed to EBV, whereas 98% of those who developed MS actually were exposed. So I would say that EBV is necessary for the development of MS in almost all cases, There is likely still some heterogeneity. The way that we used to think that NMO or MOG were essentially MS, there's probably still some other diseases that we are calling MS and that are yet to be discovered. But I would say that for the vast majority of cases of MS, those individuals have been exposed to EBV in the past. But there's a lot more in that causal pathway. So there is so much more to discover about what modifies out of those patients who get, or out of those individuals who get EBV, how is it determined which of those are going to then develop MS? Since the vast, vast majority of those who have EBV end up being completely fine.
Another really interesting aspect of this recent study was the use of an ultrasensitive biomarker, blood biomarker that's been developed in the last few years, and that has, I think, helped to pinpoint this temporal relationship to a greater extent between EBV infection and the onset of MS, perhaps even in the preclinical phase. Before, with this study, they had blood that they collected at intervals, and so I think for even though EBV had been implicated in MS for some time, I think this more tightly tied the two together, I think.
Yeah, that blood marker really kind of solidified that it's not early MS and this blood marker going up and then you get EBV. It's really EBV infection happens and then later this blood marker neurofilament light chain goes up.
And sort of a follow-up question which came, it was related to what Dr. Sicotte was mentioning about long-haul COVID. And in this one study, they identified a number of factors that helped or maybe predicted those people that would have the long-haul COVID, and one was the EBV reactivation. So the question is, well, do people with MS have, is that a worry? Are people at MS at a higher likelihood of long-haul symptoms? So Nancy, I don't know if you have thoughts on that particular question.
Yeah, I think it's a great question and one we have to answer. I don't think we have data yet on that, but I think it's very striking how similar a lot of the long COVID symptoms are to these other kind of chronic inflammatory conditions, fibromyalgia, certainly the non-motor symptoms that we see, or the so-called invisible symptoms that we see in our MS patients, and other disorders where there is immune activation. So I think it's a great opportunity to better understand this, and Epstein-Barr is, I think, a reasonable candidate to start looking into that, again, with the backdrop that the vast majority of the population has been exposed to Epstein-Barr, and it remains latent within the body forever, and could be tied to some of these, situations where it's very frustrating for the patients who are having a lot of these symptoms, and we are a little bit in the dark in terms of how to first diagnose it and even how to treat it. So long COVID is an awful situation, but it may give us a window into some of these other conditions and may ultimately help our patients in the long term. So you could imagine there could be some clinical trials to look at antiviral therapies, and then, in terms of the long COVID symptoms. And then just to go back to the studies showing that I agree completely that it's the Epstein-Barr is the necessary but not sufficient. But if we could identify high-risk groups and have an effective vaccine in those groups, for example, offspring of people who've been diagnosed with MS, could we even decrease the incidence of MS? And then with that, some of these other, debilitating symptoms. But I think it's a fascinating area, and I think Epstein-Barr is going to be at the forefront of some of these studies.
And those will be very long clinical trials, so much longer than the 2-year clinical trials we're used to related to treatments. So I've got so many questions up here, and unfortunately we're nearing the end of our time. But so for those of you that are here that have asked questions, there'll be some opportunity to ask us after the session. I wanted to wrap up with a question for each of you. What has you, I would say, either most encouraged or excited about or motivated relating to the future of treatment of multiple sclerosis and related diseases?
So I think in terms of some of the related diseases, I think there's a lot of really exciting new clinical trials going on, in particular in MOG antibody disease that doesn't currently have an FDA-approved therapy, and where there's still a lot of need. And I think that those clinical trials I'm really excited for and think might be quite effective. The other thing I think is that with how effective some of our therapies for MS and for aquaporin 4 NMO have been, I think there's a lot of renewed interest in space looking at symptomatic therapies, restorative therapies, and remyelination strategies. And I think that that's really kind of the next frontier in terms of potentially affecting disability that people already have and improving quality of life for people who already have the disease, rather than what we're able to really offer for the most part right now, which is prevention of relapses. So I think that's really the kind of next frontier that I'm excited about.
So many things to be excited about. I would say one of the things that we're focusing on are these biomarkers for both diagnosis and prognosis. And you alluded to those, Eric, in terms of some of the serum biomarkers like neurofilament. I think there's probably some other biomarkers that will be really helpful for us to monitor disease activity and efficacy of our therapies and aid in diagnosis. And we're also looking at some novel imaging biomarkers, just at our recent ACTRIMS meeting, looking at these pearls or paramagnetic rims or slowly expanding lesions. I'm very hopeful that these are going to be biomarkers that are related to more progressive disease. And thus, for the next generation of therapies that we hope will be targeting these this sort of compartmentalized inflammation. We'll have a readout. We'll have a biomarker to look at to see how effective these therapies are. And I am excited about some of the therapies in the pipeline that may be beneficial for those living with progressive MS, which I think is our biggest unmet need. So I see both benefits on both the early diagnosis side being more specific and also being able to prognosticate a bit. And then at the end, sort of in the progressive phase, having more tools that we can use in more therapies. So I think it's going to be really exciting the next 5 years or so.
Yeah, great. And both Dr. Sicotte and I have a special interest in developing novel neuroimaging biomarkers. And I think the McCourt Foundation provides us opportunities to continue to work closely together and collaborate in the future in developing some of these novel tools that we can use to learn more about multiple sclerosis and other diseases. So this wraps up our time that we have this afternoon. Thank you all, both those of you that are here despite the kind of in-between rain and snow that we have here in Boston, and those of you that are attending virtually as well. I think that one of the still big advantages of this hybrid world that we live in is the way that we can sort of extend these sorts of opportunities to reaches that we weren't able to before. So please have a great rest of your weekend, and both Dr. Vishnevetsky and I will be up here to answer a few questions that perhaps we didn't have time to get to in the session. So thank you all.
Thanks very much.